everybody. It is Rob. It's time for another member talk. We're excited about this one. This is a topic today that it's a little bit different. It's one that's been kind of on my heart to talk about for quite some time. I've been looking for the right person to talk with, and I think we found that person in Dr. Sara Murphy. Sarah, how are you today?
I'm well. I'm so happy to be here. Thanks for having me, Rob.
You bet. I'm excited that you're here. I really am. Even though it's a tough subject to talk about, it's one that definitely needs to be discussed. We need to have that conversation. But I wanted to bring you on. Sarah, you're a certified thanatologist and a suicidologist.
Yes.
And I'm sure most of our listeners are wondering what in the world is a certified thanatologist. I told my wife yesterday I was going to have this interview with you, and that's the first thing she asked me is, "What's a thanatologist?" So jump into that a little bit for me, if you would. What does a thanatologist do? What do you study? And then let's talk a little bit about the suicidologist as well.
Sure, absolutely. Two titles that are certainly tongue twisters, and I am asked that question on a constant basis on planes when we could fly and social situations. A thanatologist is someone who has demonstrated expertise in death, dying, and bereavement as a knowledge set. And a certified thanatologist is someone who has proven that expertise and education and has been reviewed by the Association for Death Education and Counseling. That's our parent organization as thanatologists. So we do the same kind of credentialing and upkeep that professionals do in funeral service and nurses and in a lot of fields. The difference being that we aren't all within the same profession. So many certified thanatologists are psychiatrists or social workers or hospice nurses or people who are working directly either with the grieving or the dying. We also have funeral directors who are certified thanatologists. And then there are we, the educators, who make up maybe the tiniest population of strict academic or professional educators. And I'm both an academic and a professional educator. So I'm happy to be part of that community too. Yeah. Suicidology, obviously the study of suicide, is a specialization within thanatology. It was also something that I was specializing in from a cultural critique process while doing my doctorate, which was in English, but which was completely tailored toward American culture and death and dying. So my dissertation was on suicide in American culture in the 1990s. I teach entire courses on suicide, and I do a lot of workshops professionally and talks on a lot of topics, but certainly suicide is really, in many ways, what brought me to thanatology and something that I really keep, in my heart and at the core as well, Rob.
Yeah. Yeah, definitely. It's something that I know a lot of people are going to kind of raise some eyebrows. Why are we talking about suicide?
Yeah.
Well, simply put, we need to. We need to talk about suicide. Suicide is rampant. It's something that we need to do our part as much as possible to prevent. Obviously, this conversation won't prevent suicide. Maybe it will. You never know. I hope it does. But we're going to put some things at the end of this that, if you are looking for help, if you do want some information, we're going to put some phone numbers, some emails. So please stick through this with us and get to the end, and we'll get some information out there to you. Sarah, how I got to ask, because I get asked all the time about being a funeral director, how did you get into this business? And to me, it seems like it's such an obvious answer, but how do you get into becoming a suicidologist? How did that come about?
I am asked that frequently, and I think even my family is still a little baffled by how it happened. Even my path toward thanatology was very circuitous. It wasn't linear. This was not my first career. Academia was not my first career. I was working in Congress and in national politics, and I went back to college and started following a different path into American studies and literature and culture. And I really just stumbled into the right course at the right time, being taught by an amazing professor, Jeffrey Berman, at the University at Albany in SUNY, the state of New York system, who is teaching a course called Love and Loss in Literature and Life. And I think it was supposed to be for 20 students, but there were 40 or 50 of us in it. And he
Wow.
had designed the entire course. He was not a thanatologist. He designed the entire course to come to terms with the recent death of his wife to pancreatic cancer. And
Yeah.
so we spent the whole term reading literature of loss, but doing kind of Freudian psychoanalytic writing through loss. And it was really in digging into the footnotes of some of what we were reading that I stumbled on the understanding that this was a field of study for real, that death, dying, and bereavement was something that I could pursue. And I was bit by it really fast. And some of my friends were not surprised because I tended to gravitate causes, social justice causes, populations who were disenfranchised or overlooked. And that certainly defines grieving people in America to begin with. And
Yeah.
then when you look at people who are suicidal or who are suicide attempt survivors or suicide loss survivors, as a disenfranchised population, in hindsight, it's not surprising that I went that route because a lot of my other specializations in thanatology, like HIV/AIDS, addiction losses and overdose, disenfranchised grief more broadly, they're really all signaling to help for populations that are the most left out, are the most unseen and unsupported. And I know a lot of people enter this field for intensely personal reasons, like funeral service. And I think for me, I started out very academically interested and cognitively interested, but the professional became personal the second I walked into a classroom and started teaching on it and realized that both the academic, undergraduate population, but also professionals in the public, like funeral directors and nurses, both of whom I work with so much, can really benefit from, a distillation of this kind of study and practice. And that's when you know that what you do can have a measure of impact and assist people's lives, which I don't have to tell a funeral director how beneficial that feels to go to bed at night and think, okay, I made someone's day just a little bit less hard.
Right.
Yeah.
I like how you put that, a little bit less hard.
Yeah.
We always hear people say a little better.
Yeah.
We hope for that. That's our obvious goal, but even just getting a little bit less hard when it's dealing with death of a loved one is
Mhm.
sometimes the best we can do and the best we can hope for.
Absolutely.
I love how you put that.
Mhm.
But Sarah, you've been a contributor. You've done all sorts of stuff within this field. One of the things and where I first found you was actually through NFDA. I don't know if you can see that if I hold it up.
I
You're a
can.
contributor to some of the different programs and some of the different articles and magazines that NFDA puts out. And this one, Grieving Alone and Together, Responding to the Loss of Your Loved One During the COVID-19 Pandemic by Dr. Sara Murphy, PhD. So that's you.
Oh, yes, that is me. That was a labor of love. And honestly, working with NFDA on any project is always such a pleasure and a labor of love. It's one of those professional relationships that happened almost by happenstance. I met someone who works at NFDA at a conference for dermatologists, and we just got to know each other over happy hour, as happens at these conferences, and kept talking after the conference was over. And now here we are. And over the last couple of years, I have been so privileged to do so much work with and for NFDA, and speak at conventions and conferences and give webinars and workshops and podcasts. And when the opportunity came up to write this booklet last spring, a couple of months into the pandemic, there was such a shared sense of urgency between myself and the staff at the Funeral Service Foundation and NFDA. We had all been thinking about the need for something like this on our own. And so as soon as the conversation happened, we really just ran with it. And I kind of locked myself down to meet a very, very quick writing deadline because, I mean, kind of tragically now, we were thinking this urgency of get this out to help families, but we've got to get this out before this is over. And
Yeah.
we don't have a resource to have helped these families in the, few months this is going to be going on. I don't think any of us thought how big the resource would get, or how widely disseminated, simply because tragically it was beyond our conception for what this pandemic would look like. 11 months in now, in terms of 500,000 loss of life just in the US. Yeah.
Well, I gotta say, I plug this every day. This is just a great, I don't know if you call it an article, a periodical, a magazine, I don't know what you would call
I
it,
think we're calling it a booklet.
a booklet. Let's call it a booklet, but to me, it just is amazing. One, in the amount of detail that's in it, but two, how quickly it all came together. I mean, this came out in the heart of, or at the height of the COVID pandemic, and what's in it today is just as relevant as what was in it when it was first written, and we're still experiencing this, the
Yeah.
stuff that's talked about in here. So it amazes me how quick it came out, and how, from an outsider it seems, oh my gosh, that must have been real easy, but I doubt it was. I bet it was pretty difficult to try to piece it all together and get it out in that deadline that you talked about.
Yeah, yeah. And I mean, I've got to give it to the staff again at the Funeral Service Foundation and at NFDA, because all I had to do was write copy. They got to put everything else together and get
Yeah.
it through publication. But yeah, looking back, thinking about, I think from our conversation about the need to have a resource like this to its date of publication was maybe 6 weeks.
Wow, amazing.
Yeah, yeah.
Well, sir, I'd like to I want to have a conversation with you, a very serious conversation, suicide. Um, I don't even know where to start the conversation. I can tell you that my life has been affected by suicide. I've had multiple friends of mine that have died by suicide. And that's something actually that uh, terminology I'm finding is something that we should discuss as well. I used to say committed suicide, but the proper terminology is actually died by suicide. Am I saying that right?
I usually use the term died of suicide, but a lot of people use died by suicide. And I do open most of my talks on suicide and all of my courses on suicide really by tackling language first, because
Yeah.
it does function really problematically in English and American culture traditionally. No one thinks anything of it, and until they do, of using the term committed suicide. And
Right.
until you really just stop and break down, the criminalization implicit in using a term like that, which is such a hangover from when suicide was literally legally criminalized in the US and elsewhere. It goes so far in beginning to peel back some of the uninterrogated stigma that we still associate with suicide. And my students are always so eager to please, and they want to get it right, and they're always asking, well, how do I say it in this tense, etc. And I always just say to them, just replace the word suicide with cancer and see if it parses, see if it works. You would never say that someone committed cancer, or
Yeah.
that they heart attacked themselves, or that they were a cardiac arrest or were a cancer. We do that also. He was a suicide. And suddenly you've turned an entire life into a mode of death. So yeah, language is important. Language, and where it is seen and how we use it, but also where it's not seen. We rarely, if ever, see the word suicide in an obituary,
Mhm.
or even hear it in a eulogy. And that, silencing of language also reinforces the cultural hangover idea that this is something shameful, this is something we should not talk about. And the tragedy of that, of course, is that the less we talk about suicide and bear witness to the pain and suffering of people who have died of suicide and who are bereaved via suicide, the more that people who are living, who are feeling suicidal, will feel like they're alone, will feel like they can't talk about how they feel or their pain, because from childhood, they're getting these signals through language and through media and through the absence of discussion that this is wrong, that this is something to be ashamed about, that there's something wrong with them.
That's one thing I've always noticed when I'm with a family that has a loved one that maybe died from cancer. Um, it's a whole different atmosphere
Yeah.
than a family that I'm working with that has someone that died by suicide. So yeah, it's that whole stigma. I've noticed that very rarely do you, like you mentioned, do you ever see that in a newspaper, in an obituary, a cause of death listed. A lot of times you will for other reasons, but
Mm-hmm.
not for that. I know a lot of, I actually know of some folks that, just won't even have a funeral because of the
Yeah.
manner of death, the cause of death. And yeah, I think it's just that whole stigma of, I don't know, I don't even know how to put a finger on it. I don't know how to really talk about it. That's, I guess, my biggest issue is I don't know where to start, and I don't know how to talk about it.
Yeah.
And I know
Yeah.
you teach a course that's like 12 weeks. We're going to try to condense all of it into 30 minutes, but
Yeah. You can just think of those 18 to 24-year-olds going home and telling their parents that for 14 weeks, 3 or 4 hours a week, all they're going to be talking about is suicide, and those parents being so excited for them.
yeah,
Um, I think I caused a lot of raised eyebrows in a lot of households that I thankfully never visit. But in terms of stigma, I think what makes it so hard to start to talk about and unpack is because it is so dynamic in and of itself and so complex. The stigma
mhm,
itself is so complex because it has historical origins, it has cultural origins, it has religious origins, and it's all pressing and complicating on itself, and becoming stronger in a way, kind of like a cancer growing itself,
yeah,
because it's being still reinforced through a lot of our institutions in dominant culture, religious institutions, medical institutions. I've met some really well-intentioned, wonderful coroners who have, transparently said that they've listed other causes of death as a kindness to the family, instead of listing suicide, and maybe aren't expecting the kind of indignation I would have in
right,
response to that. Not only because we really need to know where we are in terms of numbers, but what you're saying to the family is, I'm lying to help you, because the truth is too shameful. The
yeah,
truth is something we should all feel bad about. So let's obscure it by saying respiratory arrest, cardiac arrest. And certainly, in terms of other institutions, religion. Many Americans, even if they are not, devoutly practicing their religion of origin, have strong senses of faith. And certainly, as Christianity and Protestant Christianity is the dominant religion in American culture, there are biblical origins for suicide as being interpreted as an unforgivable sin,
mhm,
Judas, right? And so, then you look to a sect like Catholicism, which has tried recently to soften its language a bit in its catechism. They had a very long footnote added a few years ago on suicide, that basically said, well, we know that we don't know what's really in a person's heart. And to that, I would add, not that anyone in the Catholic Church would want to know what I would add to a catechism, but I would add, we don't know what pain people are in.
Right.
Pain is not, frequently visible, and the most insidious pain is not visible. So, that doesn't always comfort someone who is grieving a suicide loss if they've been told since childhood that their religious institution treats this as the worst shame, the worst sin, the deepest and most unforgivable act of despair, turning one's back on God. So I don't think that's helped either. But I would never blame religion for everything. I think it's all that messaging coming from so many directions that's made this stigma so strong, even for people who have been personally affected. And for those who have been personally affected, those stigmas can be the most damaging, whether they're survivors or whether they're walking around carrying this weight of their suicidality and thinking there is something wrong with me and I'm not deserving of help.
Do you think talking about it um, helps that healing a process a little bit more than trying to hide it, trying to be ashamed of it, just completely hiding it, like you said, changing cause of death, that sort of thing? You think opening up and talking about it publicly, or just with your local group of people, of friends, of church members, whatever, do you think that helps families heal?
I certainly think it can help families heal. And I think ideally it would always help families heal.
Mhm.
I'm a big proponent of talk therapy. I have some Freudian roots to me as well, at least in terms of things like a talking cure. But what's tricky with suicide, of course, because of stigma, versus someone who, say, has lost their partner to cancer, is that the suicide survivor knows that whomever they approach may not um, give them the kind of response that they need because of these stigmas. So what can be really valuable are relying on kind of tried and true suicide support resources. And I know you're going to be sharing some with your
Right.
listeners as well. And also to find suicide specific support groups,
Yeah.
because going to, if you lost your partner or your child to suicide and just going to a support group meant for parents who've lost children or people who've lost their spouse. If you're a suicide survivor, you're not going to get the kind of benefits of kind of that shorthand of the particularity of that grief, sitting next to someone who, didn't have that kind of complexity in the
Right.
loss itself. So the American Association for Suicidality, certainly the American Foundation for Suicide Prevention, both I think keep pretty updated lists of both state chapters, and then which kind of support groups may be running out of there. And certainly some religious institutions will run support groups, but whereas I would never advise anyone to hide the mode of death, whether it's suicide or another stigmatized cause of death, like an addiction related death.
Sure.
Um, I certainly understand the care, and the anxiety of trying to find the audience, even if it's just another person, a friend, a neighbor, a co-griever in the family, where you can transparently talk about the loss and get some kind of empathic and attuned response, instead of someone who's going to impose their belief system or their losses or their assumptions about what you're feeling on you.
Hmm. Yeah, like you said, we will post those at the end. I do want to get that out there. We talk about suicide prevention, um, and I hear people say stuff like it can be prevented each and every time. And I think that falls into I think it falls into more of a myth category. Are there myths surrounding suicide that we think, but maybe may or may not actually be accurate? Can we do some myth
Sure.
busting a little bit? Do you have some of that?
Excuse me. There are many myths. There are many myths surrounding suicide as it is culturally received and understood. And I think, maybe I'll loop back to your question on prevention and preventability, because there's also just a really deep misunderstanding of how suicide happens. So maybe I'll do a little myth busting first, and then get to the root of how suicide happens to the best that we know, right?
Sure.
One huge myth, and I do like to include these in my workshops because we've heard all of them, even if we don't believe in all of them. But there is such an inextricable link that's been drawn in dominant culture between clinical depression and suicide, to the point where we've almost collapsed the terms and made suicide this eventual, almost inevitable possible outcome of living with clinical depression. And that damages multiple populations. That damages people who are suicidal but do not have clinical depression. It also damages the millions of people living with clinical depression who will never attempt suicide and who may never feel suicidal. We know in point of fact that most people who live with clinical depression are not suicidal. And that most people, and that many people who attempt suicide or who feel suicidality are living with other kinds of mental health problems, and often with no diagnosed mental health problems. Depression is not even the mental health condition that loses the highest percentage of people suffering from it to suicide. It's anorexia. 20% of people with anorexia die of suicide. No one talks about that. And that's a staggering number.
Yeah.
So, that's one thing that I think we need to move away from, because that means that people who are living with anxiety disorders, bipolar disorder, different personality disorders, but also the people who have no diagnosis, but who are feeling suicidality, it's not reaching them. They feel like they don't even have the right because they haven't gotten a diagnosis. They're not on a medication. So that's one myth. Another one, and I think this speaks to your question about whether it's beneficial to, really talk about it, is that there was for about 100 years in Western culture, there was a myth that was rooted in really nothing scientific. We call it the Werther effect. It's based in literal fiction. That if you talk about suicide, you could risk becoming suicidal or causing someone to become suicidal. And this is an outgrowth of what we call contagion theory, the idea that suicide is contagious. And even now, 2021, sometimes when I tell other academics that I teach courses on suicide, they'll ask me if I'm ever worried about the risks of teaching it. And while I worry about many things in regard to executing a course well, I have never, and for good reason, worried that a course would cause a student to feel suicidal. I might, if a student comes to me and says they want to take the course and they're feeling suicidal, sit down with them and talk about whether they feel that they can do that, whether they feel like maybe get back into therapy if you also want to take this course, make sure there's safeties in place so they can, step out if they need to. But ironically, most of my students with suicidal histories feel far better and more empowered by learning more about suicide and by learning about it in a factual way and in a critical way instead. And that empowers them to also push back when they hear a lot of these myths too, and understand that they aren't alone. Contagion theory is going to be disproven, I think, within the next decade. We've been on a long road to just throwing it out, but I know that the vestiges will still be there. I hear from a lot of school administrators after a suicide death has happened who are either, worried about how to address student populations, address the faculty, and handle it right. I often hear like, what's the proper thing to do? And I always start by asking them, what would you do if a student had died in another way? What would you do if a student had died tragically in a car accident or
Sure.
from cancer. And there's usually something set up in that district to memorialize students. And unfortunately, even now, and of course, with adolescent suicide deaths at a staggering number, I hear from them more. Even now, they frequently would instinctively gravitate toward doing nothing, or sometimes to memorializing to the degree where they're romanticizing the loss, neither of which is healthy, neither of which is beneficial. I mean, I've worked with students whose high schools didn't allow them to take time off to go to the funeral of a classmate who had died of suicide. And I mean, what help can you possibly be providing? But it's coming from that contagion theory, like it's gonna spread.
Sure.
And what's really hard, I think, for people to understand, especially if you see, say, multiple suicide losses in a family system, or occasionally we'll see these hot spots where like a town has an uptick in suicide deaths or a school has an uptick in suicide deaths. We have to stop thinking about it on the surface as being spread from one to the other and think about maybe what shared common sources of pain are underneath that might be contributing to the potential suicidality
Mhm.
individually for each of them. And that's kind of a tough way to start reframing your mind, um, because we've been told for so long, well, suicide's caused by one thing. And, I hope I'm not talking in circles. It's often like going back to the depression myth, right? Well, they were depressed, they tried to get help, the help didn't work, this was the outcome. Or often, if there was not a diagnosis of depression, survivors will be desperately trying to construct a narrative that makes the outcome make some kind of sense. And that's often this struggle to find one cause, a breakup or a divorce,
Right.
a job loss, a diagnosis of something else, right? Um, and the problematics with that is that we know that suicide is never caused from just one event or just one stressor, that like any other life-threatening cause of death, suicidality is complicated. And as much as we in the field know about it now, we know that there's more that we don't know, because we know that there's more about the brain that we don't know than what we do, let alone the mind, which isn't quite the same thing as the brain.
Mhm.
So, I mean, I've gone a little far afield from contagion theory here, but that's sort of the damage of what contagion theory does is say, well, if it were as simple as just talking about suicide could cause suicidality, you would not have any living older suicidologists by any means. So
Sure.
there's that. Another myth that I hear a lot, and it's really, again, maybe a problem of language, is people talking about suicide being a quick fix,
Mm.
or an
Yeah.
easy way out.
Mhm.
Or, I mean, I could recite these in my sleep. Um, a permanent solution to a temporary problem.
That we've heard quite a bit.
Yeah,
Yeah.
yeah, we've heard all of them. And while we also know that there are suicide deaths where the attempt appears very spontaneous versus others where the attempt was obviously very planned over a long period of time, if we step back from the tunnel vision of just looking at that attempt and look at the whole picture of suicidality, these never come out of nowhere. And I usually tell my students to think about an iceberg, like whatever you can piece together about what was going on with the person who died, you are still only going to see the tip of that iceberg.
Right.
And all the rest of that was lurking under there and growing in strength over some period of time. And in all of that time, there was also an accumulation of pain, pain until the pain became so unbearable that the person genuinely could not see another option. And that's really hard for people to grapple with. And I talk to survivors who really struggle because they say and they believe, I was there for them and we were going to get them this help and we've been trying to get them this help, and they could have just picked up the phone. But the suicidal person who is end stage, as I call it, because this is a life-threatening condition, the suicidal person who is end stage at the point that they are about to make an attempt, they genuinely cannot see another option. And as frustrating as that is for us, if you can make that sort of transcendent leap into trying to consider what that would feel like, they genuinely can't see another option. And no one at that point could force them to see. So where prevention is helpful is before that happens. Unless it is literally like an interrupted attempt, and you can get them somewhere for help right away. We know that just like any other life-threatening cause of death, the earlier intervention can happen, the earlier treatment and help and support can happen, the greater odds there are of survival. Yeah, but there's no, I mean, I've worked with a lot of suicide attempt survivors, and not a single one of them thought, oh, this would be a quick fix. This would be an easy way out. Most of them wrestled for months with thinking even about the attempt and thinking and weighing, can I live with this pain that much longer? And, there's nothing, this sort of goes into the language that suicide is wrong. Suicide is selfish. Suicide is for the weak, for people who are cowards. Some of the bravest people I know are the people who are managing to drag themselves out of bed when all they could feel was the weight of that pain.
Right. What about age? We're seeing a lot of younger, I know you mentioned adolescent suicide. We're seeing more and more of that. Younger teenagers, even younger adolescents. I don't know if we're seeing more or if it's just being reported more. It's being looked at more. Is it something going on there that is that you can think of that is causing younger and younger and younger either attempts or even successful suicides?
Yeah, there's definitely something going on there. But there's also something going on, excuse me, across the lifespan. Suicide is on the rise again. It really hasn't slowed. We're kind of at the point where we're trying to celebrate the victories of the increases being a little less than the increase of the previous year, which isn't much celebration. And it will take a while, for example, I mean, here we are recording in February 2021. We're not going to have accurate numbers from the CDC on 2020 in relation to suicide for a while. And I am someone who wants them. We want to see them for a while. But since April, I mean, since maybe a month into this pandemic, one of the things that's always been in the back of my mind is I am dreading seeing the suicide numbers from pandemic. I think we're going to be looking at a huge spike. I fear that we will be looking at a huge spike, and we are in such a tenuous cultural position right now. I don't think anyone feels 100% safe and secure in their life right now, not just in terms of their health, but job losses, political divisiveness, racial tensions,
from every direction,
generation wars, class wars. I mean, you name it. And then you look at actual grief and losses. We do know that in the first 3 months of the pandemic, the overdose death rate leapt by 19%.
Wow.
Huge, staggering increase. I'm not saying that that's going to track exactly, obviously, to suicide, but I think it will increase. To your bigger question, really, I mean, not really COVID aside, but not COVID exclusive, we've seen, I think, a lot more toward adolescent suicide in the last decade. I think that it was targeted rightfully from government agencies on down as something to be concerned about. Awareness campaigns, more literature, more instruction for therapists on adolescent suicide. I think reporting has gotten better to some degree, maybe more with male adolescents than female adolescents. But it's also a question of looking at rates versus numbers.
Mhm.
And right now in the US, for 10 to 34-year-olds, suicide is the second leading cause of death. 10
You
to
said for
34-year-olds.
10 to 34.
Yeah.
My goodness.
Yeah. So that encompasses multiple determining age groups being studied, all at second now. When I started teaching on suicide, it was like the third and fourth just for adolescents.
Yeah. Just out of curiosity, what's the first? What's the first cause?
Well, for 10 to 14-year-olds, it's cancer.
Is it?
Yeah. And after that, it is accidents.
Yeah.
Accidents, and then suicide, and then homicide.
Wow.
Which my students are always really surprised by. 18 to 24-year-olds, third leading cause of death is homicide. And then I remind them of relatively what a privileged position they are in, both economically, geographically, and racially, to not ever have to worry about homicide. In large part, not all of them, obviously. Yeah. So those are rates, right? So we look at that and it's horrifying, and it's rightfully horrifying. And there's no one single cause, because for each individual death, there was no one single cause. But then if we look at numbers, we know that the majority of people dying, period, in America of anything are not 10 to 34-year-olds. So if we look, say, to 35 to 54-year-olds, suicide is the fourth leading cause of death, but more people in that age group are dying of suicide than adolescents.
Sure.
If you cross age and gender demographics, it's actually middle-aged men who are dying the most of suicide. But again, I mean, how do you start weighing these lives, right? But it's important, really just to look at, we're having a crisis in adolescent suicide. I would say in pediatric suicide, I wish we studied younger than the age of 10. I wish we collected that data. We don't. But we can't stop paying attention to middle-age suicidality. And the demographic that's always been left out, and for no good cause, is the elderly, the geriatric population, particularly those who are bereaved, are at really high risk of suicide as well. And we don't see those campaigns, right? For, talking to grandparents or older persons, and therapy, and getting help, and being able to, recognize warning signs for suicide. In that population, we don't see that at all.
Within those age categories, in particular, the adolescent and pediatric suicides, is there any one thing that you can look at and say, this is one of the things that we're seeing as a major contributing factor to this death? Is it, I don't even know what it would be. I mean, is it parenting? Is it not liking your parents? Is it school bullying? I mean, is there, what could you look at that would cause something? Is there anything out there like that?
There would be no one unifying commonality that, I would want to even point to and say this could make a huge difference, because then I'd either have to talk about like 20, or not single one out per se. I don't think it has anything to do with liking or not liking one's parents, and I don't think, I'm going to choose my words really carefully here. I think it's incredibly important that education systems have, in the last several years, started focusing on recognition and elimination of bullying. There's only so much they can do, because most bullying has moved online. That being said, I think the emphasis on bullying prevention as a means for reducing suicidality has been overemphasized. I'm not saying like, let's bring it back, but I'm saying if they're thinking, if we take care of the bullying piece, our kids aren't going to become suicidal. They're going to be in for a reckoning, because there is, for every suicidal brain, whether it's 10 years old or 90 years old, there are going to be so many different pieces of the puzzle that have to be put in place for that person to be actively suicidal. And, as divisive as our culture is right now and our country is right now, and as kind of radical that trends and changes in tropes like parenting have been in the last generation. And I inherit a lot of these students at 17 or 18 who have been, for want of a better term, helicopter parented. I don't see them as being any more or less likely to develop suicidality. It may make them more likely to act out while in college because finally every moment of their life isn't being scheduled for them. But in terms of mental health outcomes, I just don't think we've got the data to support that on, a widespread level, which is of course frustrating. I would love to be able to say to you, if we could fix this one or three things, then we're going to prevent 10 to 18-year-olds from developing suicidality, but we don't have it.
Sure, sure. Well, we're getting a little bit lengthy, which is fine because it is a very interesting. I don't know if that's the right word or not, but it is definitely a topic to me that sparks a lot of interest. It's a topic that I think that we need to discuss more. But I did want to hit on a couple of quick things with
Sure.
you. One is that stigma about suicide. When somebody dies from suicide, we talked about that at the beginning. There's a stigma. But if we switch gears a little bit and we talk about, like in Washington, we've got death with dignity, it's called, where there's a process. You have to prove that that this isn't just, you're not just going to end your life by suicide.
Absolutely.
You have an incurable health issue, written out by doctors, it's proven. That stigma doesn't seem to be there at
Mhm.
that point. Is it because of the fact that it's something that was chosen in public and talked about and gone through the medical profession and all this other stuff, versus somebody that, oh my gosh, they just died from suicide and we had no knowledge, we had no, we would have never thought. Is that where that stigma comes from, or am I missing something there?
Oh, what a fantastic question. And I'm so glad you brought up death with dignity. I actually wrote an entire dissertation chapter on death with dignity and really did a deep dive into all the numbers in Oregon and then in Washington. And I'm a big proponent of it, and a big advocate for its legalization in other states. Um, and it's funny because sometimes I'm asked whether I incorporate death with dignity or theories about euthanasia, which of course death with dignity is not euthanasia, in my courses on suicide. And I always say no, because thanatologists do not treat death with dignity or aid in dying, as it's called in some other states, as having anything to do with suicide. And psychologically, it has nothing to do with suicide. It doesn't present the same. It doesn't look the same. And it's amazing, I think, how quickly debates on state levels are happening again with aid in dying, because it kind of went away nationally, I think, a few years after Washington, and then came back again. I think because of Brittany Maynard largely and her publicity of it and her dying process. But we do know that the majority of people surveyed support aid in dying. I think because it's something that on the most fundamental level makes sense to most people. And I think for any of us who have been with someone who've had a protracted illness, who are suffering, who are of sound mind, who are in uncontrollable pain. And we know that, I'm a huge fan of hospice and palliative care groups, but hospice. And even hospice knows that 10% of cases, terminal pain can't be controlled. And we also know psychologically, even for people who get that and never use it, they report reduction in their pain just knowing they have it and can use it if they want to. It's so empowering. And maybe that's it. Like, we want the comfort, we want the care, we want to put the dying person back at the center of their own lives and be an agent instead of a subject. For the suicidal person, we can't really look at them as a subject or an agent, because the suicidal person who attempts suicide, this is a function of a mind that isn't working right. It is them, but it isn't them. And that's really, really hard. So, I think it's much easier to speak of aid in dying because there's a universality. We've all seen someone or loved someone who went through a dying process that maybe we even wished we could have helped them hasten,
Right.
just to get them out of that pain. But until we talk about suicidality, until people are willing to say to each other, you know what, I used to feel suicidal, or I had this experience, or for this month of my life, I really thought that was going to be the end. If we break those silences and people start talking and recognizing that this is a common mode of suffering, then I think more and more people will understand this population is just as deserving of help. And the difference being, suicidality doesn't have to be terminal. And that with early intervention, with assistance, and with just cultural and interpersonal validation, it can be prevented.
Mhm. Okay. I wanted to briefly touch, your introduction here talks about that amongst all the other programs that you teach, which is quite a few. Let me just touch on those. Interdisciplinary courses on bereavement, loss across the lifespan, loss in literature and life, writing loss, mass death, addiction, disenfranchised, grief, HIV and AIDS, and then end of life care ethics. That one kind of caught my eye, the end of life care ethics. Can you briefly just share a little bit about what that is with me?
Sure. I haven't actually taught that course in a while, but I still do some workshops, especially with nurses, on sort of developing their professional ethics, and then, really drawing from some of the traditional leaders in the field for means of best practices to support those who are dying. And I don't think any of it would be really revolutionary for people who are working in the deaf space, excepting maybe really needing to keep empathy front and center, empathy over sympathy whenever possible, front and center, and really practicing the kind of attuned listening and meeting of needs of the bereaved, that people who are in organizations like hospice are so trained to do for the people who are dying, or death doulas are so trained to do for people who are dying. And if we look to some of the leaders in the field, even people who've been kind of misappropriated, like Elizabeth Kubler-Ross, and think about, the genuine personhood and love and care for the whole person, really the holistic approach of end of life care. There's so many things that still hold true decades and decades later in our crazy contemporary cultural moment, where most people who are dying have an urgency and a desire to speak, if we give them the space to be heard, and that anyone who is dying or suffering has, I believe, the right to have someone bear witness to their suffering, to bear witness to their testimony, even of suffering, or of their life review, without judgment, without interruption, without even the kind of linguistic coercion we do with people sometimes, like how are we feeling today, or infantilizing the elderly when they're dying. I've talked to a lot of young nurses rather sharply who talk to their elderly patients as, cute, sweetie, honey, like cut all of that, maintain the dignity there. But even linguistic coercions like, you must be feeling so. And we hear that with the bereaved a lot too, them having to grapple with very well-intentioned people saying, you must be feeling so upset, you must be feeling so angry, you must be feeling so robbed. And that's a form of disenfranchisement. The minute we hear that, it's telling our brain, this is what this person expects of me. So either I need to go through the long route of explaining, no, I don't feel that way. Actually, I feel this way, or give them the easy answer and know that this isn't someone you're going to be coming to later. And that's the same for those who are dying. They need people who will sit and be with them, but who will also ask them questions. When I teach my large lecture, introductory courses on death and dying, we always start with a tenet that sounds so simplistic, but kind of throws them through a loop, that the dying deserve to be treated as living beings. The dying are not dead. They are still complicated, biological, sociological, psychological creatures with a life history behind them, with perhaps aspirations still in front of them, with needs, with wants, with opinions, with emotions. They're not dead yet, and they deserve to be treated as living.
Well, it sounds like there could be an actual course made of just verbiage, linguistics, of what to say, what not to say. I mean, we hear it all the time. Oh, I know how you're feeling. No, you don't know how I'm feeling.
Yeah, that's one of the worst.
But I think that we do it because we don't know what else to say.
Yeah.
I mean, it's just like saying, well, they committed suicide or they were a suicide. Like you said at the beginning, no, they weren't a suicide. They were a person. They are a person, and that they died from suicide. Just like you say, put cancer in there, or some other form. Well, Dr. Sara Murphy, this I usually say this has been a fun topic. It's not. It's not a fun topic, but it's a very interesting. It's a very important topic. And I'd love to sit and talk with you more about it. I really would.
Yeah, that'd be great.
Love to get you to come back on and maybe do round 2 and maybe dive a little deeper that time too.
Sure.
But this has just been, it's been interesting. And I do want to, I know you were kind enough to share with us a number of different phone hotlines and different things like that. And we'll post those at the end of the video here so people can see those. But if there's somebody that would like to reach out to you and maybe ask a question, do you have an email you wouldn't mind sharing with them?
Absolutely. It's Sara Murphy, Death Educator, and that's SARAMU, Death Educator @gmail.com.
Okay.
I'm also on LinkedIn and fairly easy to find there. There's not too many Sara Murphys running around as death educators.
We had a little bit of a internet glitch there, but it was Sara and then the last name Murphy, MURPHY, Death Educator @gmail. And again, I'll post that at the bottom so people that maybe misheard that will be able to read it.
Great.
So thank you. Thank you for coming on and talking with us. Thank you for what you're doing. And I can't imagine that it's easy to do, especially when you have a room full of students that are wondering. I think some of them may be wondering, why did I take this course? And others are really wanting to learn. But, I think that I know if I was in the course, I would come out today knowing that I've learned at least 3 or 4 new things, I can tell you right now, just from our conversation. So
wonderful.
Thank you for doing that. We do want to get you back on. We're going to go ahead and close this out now. Dr. Sara Murphy, everybody, thank you so much for
having
joining.
me.
You bet.